Hi, good morning, good afternoon, good evening, everybody. It is actually a little bit after 5 p.m. in Paris, 4 p.m. in London, 5 p.m. in Copenhagen, 5 p.m. in Madrid, 5 p.m. in Amsterdam, and last but not least, it is 11 a.m. in New York. I'm Mohamad Mohty from the Sorbonne University and Saint Antoine Hospital in Paris. And it is my great pleasure and honor to welcome you all to this special educational activity brought to you by the International Academy for Clinical Hematology. And our topic for today is a very special one, which is dedicated to the treatment of acute lymphoblastic leukemia. And acute lymphoblastic leukemia plays a very special role, I think, special place in oncology in general, because this is where historically we started seeing the tremendous advances in terms of improving survival, going from around 30% in the 60s. Now we are more than 90%. And all of these great advances were mainly achieved historically using conventional, actually, chemotherapy. And this is really quite incredible. But the story didn't stop at the level of conventional chemotherapy, because more recently, in the last 5, 6, 7, 8 years, we've seen the advent of immune therapies, especially bispecific antibodies, T-cell engagers, namely blinatumomab, which is now approved and widely used in many places. We have also antibody-drug conjugates, for instance, inotuzumab. And last but not least, we have, of course, CAR T-cell, which are really making a big difference in the life of many refractory ALL patient. And recently, I think we had the 18th anniversary of Emily Whitehead, who was the first child to receive actually salvage CAR T cells. So in order to discuss the recent updates and the current status of the treatment of ALL, I'm joined today by a highly distinguished panel of top experts, namely Professor Inge van der Sluis from the Netherlands, Professor André Baruchel from France, Professor Nicolas Boissel from France, Professor José Maria Ribera from Spain, and last but not least, Professor Kjeld Schmiegelow, I hope, from Denmark, and I hope I'm pronouncing all of this correctly, and you may have noticed it's just by alphabetical order. So thank you all for joining us to this exciting activity, and please do not hesitate to send your questions, to share your comments. I'll do my best to distribute these comments and questions with the panel and the different experts. So my first question to all of you, just to get your opinion about these latest advances in ALL, and especially, what do you consider the value of the role, for instance, of immune therapies today in ALL? So in general, I would say ladies first, but of course, I don't want to impose on you, Inge.
I can start, of course. Yeah, immunotherapies will be of more importance in future protocols. We recently showed that in infants in upfront therapy, that the toxicity was really low of blinatumomab, and that we also increased the survival in the KMT2A rearranged infants a lot. So that shows that it's already used in upfront treatment, but for children, it's not. We can't use it yet, so it's only in studies. In other studies in the IOPFM, they are using it also, blinatumomab, now in their upfront protocol. And in the altogether protocol, we're using inotuzumab. But these are all studies in frontline. And we know from the relapse protocols, of course, that it's very useful, and also the CAR-Ts, of course. But maybe André can tell you more about the CAR-Ts.
So, André, you are the designated volunteer now.
So I of course agree with what Inge just said. I just want to point out that besides very specific population where prognosis has been dismal, it's not so easy to say how will we introduce immunotherapy in childhood ALL, precisely because, as you mentioned, we obtained very good long-term results with conventional chemotherapy. So to depict the right population to test immunotherapy in is not so easy. Coming to CAR T-cell, because it was the question, currently there is a trial, as you know, CAR T-cell have been very successful in very advanced ALL, second, refractory, relapse, etc., saving probably half of the patients who have been condemned if not used. The question now is, can we introduce these so-called living drug earlier in the protocol? And at the moment, unfortunately, there's no trial in first relapse, or at least no big phase 3 or even big phase 2 trial in first relapse. And there have been very few attempts to use it in first-line ALL. One attempt has been tried by some of the high-risk patients in the recent Chinese paper, where they have used very smartly, in my opinion, 2 CAR T-cell at the same time, which are CD19 and CD22. This is the largest series, nearly 200 patients with first-line ALL. At least some of these patients were first-line ALL, sorry. And the other trial, which is currently just resuming, is a so-called Cassiopeia trial, which is using Tisagen Luclocel. And for high-risk NCI population with nearly end of induction failure and at least persisting MRD above 10 to the -4 during consolidation, the idea is after only 3 blocks of chemotherapy, which is induction, consolidation, and 2 or 3 blocks of methotrexate, high dose, to go with CAR T-cell after fludarabine cyclophosphamide. We don't know yet the result of this strategy, who wants to replace transplant, obviously, because it's a population with a prognosis less than 50%. That was the idea of this selection of this population. We will have to wait a little to finish the trial and have the results.
Excellent. Yeah, thank you, André.
The situation in adults is really quite different. And the major advances have occurred in B-cell precursor ALL, especially by introducing immunotherapy early. And there is a phase 3 trial that has demonstrated survival advantage when used in consolidation. So, and there are multiple initiatives with blina, inotuzumab in first line, in induction, consolidation, even in the pre-phase. So there is the way that we have to proceed. And in Ph positive ALL, we have successfully combined it with TKI, with outstanding results that persists over time. So there are good news for B-cell precursor ALL, not so good news for T-ALL.
Can I just add that we are in some way being impatient, and we are some way burdened by our successes. And it took 70 years to go from the first trial demonstrating that we could cure some children or have efficacy, back in 1953. And there's still a number of the drugs we don't know how to use optimally, but that has been tested. We also don't know what the duration of effective exposure is. Not all patients need the 2.5, 3 years that we give currently. Many are cured after 1 year. It may in some way reflect that may be the timeline that you need for CAR T-cell persistence. So my prediction will be that we face the same situation. We start with the worst of the worst. We get surprising results. And then we need to address the three main challenges we have today. One thing is efficacy. We know CAR T is highly effective. The other is the toxicity, which is a major burden to our patients today. And the immunotherapy may be one way to avoid toxicity, and it's been tested in that respect for some patients. So many have been using Blina simply to avoid the toxicity where the standard therapy has been intolerable. And the last thing is the cost. So we tend to say, well, the CAR T-cell therapy in itself is very toxic. But if you add together all the days that a patient in first-line therapy need to spend at the hospital, sometimes in intensive care, very expensive supportive care, it may be that having a better definition of which patient would need it will have a massive reduction in the cost, and it may be balancing out. So we are starting on a journey, but my prediction will be that it will take years until it reaches what we call today standard therapy patients, even though these patients are very burdened by toxicity, and today they are more likely to die from toxicity than to die from the leukemia itself. So it's an interesting journey, both for us and even for developing countries, but it needs the refinement, and that would be a slow process. So we're very happy that the crosstalk between pediatricians and adult hematologists very frequently is spearheaded by the adult hematologists, because you have a more challenging population and are more willing thus to test novel treatment approaches on which we can learn. So the collaboration between the various age groups has been much more profound in recent years, and it's really a win-win situation.
Nicolas, you'd like to add something?
No, clearly the situation remains different in adults and pediatricians, just because even if we have made some huge progresses by improving the chemotherapy in the last 20 years, we have probably reached like a ceiling in terms of toxicity, and also in terms of improvement of overall survival, due to the fact that probably the disease is not the same in children. That's not more than probability. It's not the same disease. And just also because when we're saying we're using a pediatric inspired chemotherapy, in fact, it's not really the same. It's not the same strategy. We decrease the dose intensity. So if we want to go further, like Jose Maria said, we have to implement some new strategies. And the more exciting in the field for adult population, it's BLIN, of course. And we have exciting results that came in the last 2 years, including the phase 3 from the ECOG, the E19 study, of course, in MRD positive and in MRD negative patient frontline. But I would like to comment about the elderly population of patients, where huge improvement came from ADC, inotuzumab, by 2 studies, one from the MD Anderson and the other from the EWA group, the European group, where low-dose chemotherapy was combined to inotuzumab and showed that we could improve the overall survival from about 20–30% of long-term survivors to about 50%. And that perhaps not enough in this population of patients, but that was considered as a huge step forward for this very high-risk population of patients. And we will discuss that further, but in this patient, we cannot use clearly the same strategy and the same drugs than in the younger population of patients.
Thank you very much, Nicolas. And I think Kjeld raised some important issues about the treatment on how to optimize efficacy, reduce toxicity, and improve safety. But before just going into all of these details, because at the end of the day, once we have reached, as most of you mentioned, a certain level of high survival, actually it becomes more about optimizing on how we can further reduce and improve the safety, the quality of life of the patient, and the burden of the disease. But before this, I think you alluded, Nicolas, Jose Maria, to this issue of treatment in children, in adolescents, in adults, pediatric inspired. Can you just clarify to our audience the subtle differences? What do we mean when we speak about a children-inspired regimen versus, an adult regimen? What is the philosophy? I see Jose Maria, you're shaking head.
Yeah, I think that this distinction between pediatric and adult type trials is obsolete now, because adult physicians are using really pediatric inspired trials in the sense of using essential drugs for ALL, such as asparaginase, this one. Second, reducing the myelotoxic drugs, full myelotoxic drugs, and also reducing the use of allogeneic stem cell transplantation in first line. These three elements are elements of pediatric trials that we are implementing in our current trials. I think that currently the distinction is really, it's a matter of a semantic matter. Adult physicians are using pediatric inspired trials, and we have learned a lot of pediatricians in this sense.
So yeah, the definition from the AOA population is moving from country to countries. In US, it's a pragmatic definition, 15 to 39. What does it mean? It means, I think the first message is that we should stop to consider that the treatment is hugely different in younger than 18 and older than 18. There is no reason to stop with 18. And if we could make something clever, probably we would make a continuum between children and adults, decreasing the dose, adapting the dose. And the Boissel story is about to implement in a large population of adult patients a pediatric-inspired regimen from 18 to 59. In fact, what we realized is that for a patient older than 45, this specific strategy was too toxic, and we had to decrease. And in fact, if you the other countries, other strategies, then they are built in children, but it can be applied up to 30, 35, 40, 45 years old. So we have to think ALL as a continuum from 1 to I don't know, 70, 80 years with the topic of chemotherapy and decrease the dose and not making so huge, difference which age range, which creates, and it has been shown in registries in US, if you change, you make huge change in your chemotherapy strategy, then you also have some drop in survivors, and what has been observed with patient 18 years old should not be now observed with a 40 years old or 60 years old. So we should think about a continuum in terms of chemotherapy intensity in adult patients.
André, you wanted to comment on this.
Yeah, I fully agree to what Jose and Nicolas said. I would like, nevertheless, to point out that when you look at biology is not the same, and some entities appear in the childhood period and disappear in the adult period. For example, 1221 translocation leading to ETV6-RUNX1 or hyperdiploidy. These are really childhood disease which disappear in the adult setting, more or less. So if the discussion of today has something to do with what will be the future, it is possible also there, beside the biology of the disease, also the biology of the immune system is not the same in infant, childhood, adolescent, and adults and elderly. So probably combination of learning more about biology and immune status of these patients will lead to concepts which will combine both, and maybe the treatment of a 1221 in a 5-year-old girl or boy will not be the same than the treatment of a 13-year-old boy with pH like ALL and so on. We could leave with the demonstration, but I think that the idea of the duality between biology and disease and status of the immune system of the child or the adult will be of utmost importance for the future.
Kjeld?
Yes, I would like to add that if we should make age cutoffs, the differences really occurs at the age of 10. Adolescents are almost the same as the young adults when the frequency about T-cell leukemias, the cytogenetic subsets that André mentioned, 1221 and high haploidiploidy, they basically disappeared almost when we come to 10 years of age. And when we look at the toxicity profiles as well, things like osteonecrosis, pancreatitis, thrombosis risk, there the adolescents and the young adults are much more similar. In the older age group of adults, it's not so much that they need a different treatment, but they will not tolerate the same treatment. So the toxicity is a major issue. The immune suppression is a major issue when you turn 45 to 50. There may be some young 50s that can do with it, but very frequently we'll set the cutoff at 45 to 50. And then the last issue, when we treat children, the vast majority have no comorbidities. That means when we admit them to hospital, prior to the admissions, they didn't get any medication for any chronic disease. And that changes as patients get older. And we know very little about these drug-drug interactions. So there's a lot to learn. And since the comorbidities are more frequent in the adult population, we have a lot to gain from this collaboration, not these for the teenagers. And then lastly, the BMI issue. Children tend to be more physically active. And we know high BMI plays a critical role in the tolerance for a various number of drugs. And we sometimes postpone the introduction until a later phase during induction, exactly because that specific intolerance. So how it influences toxicity profiling, how it influences immune system function, and how it influences pharmacology hasn't really been mapped well. But we know, if we look at the adult data, that BMI is one of the major risk factors. So inactivity and a high body mass, including liver steatosis, is clearly a risk factor.
So Inge, I know in the Netherlands, everybody drinks milk without any age limit, even at lunch. Do we consider there is no age limit for being a child in the Netherlands?
There is, because you can start drinking beer at 18. There is a kind of a difference. In the Netherlands now we treat the patients up till 25 years of age with the Altogether protocol, but Novo is using it till 45 years of age, and it differs between the countries, but you can use this protocol up till 45. And there are, of course, some dose reductions for the older patients, and we start PEG asparaginase later. For instance, we reduce the dose of PEG asparaginase in these patients. So there are some differences, but not huge differences.
Excellent, thank you very much. So when it comes to the advances in immune therapy, I think all of you agreed that it's a true revolution. But we still don't know exactly when, how, in which subgroup, which population. And there is, of course, and the ICH has really a very broad international audience, and we know that accessibility and affordability of drugs is not the same everywhere. And actually, we owe the best treatment to patients wherever they are. So that brings me to the issue of the importance of conventional treatment. And I think you all insisted on this, that there is clearly a room for improvement, even when using exclusively conventional chemotherapy and conventional treatments in general. So my question here is about, and please correct me if I'm wrong, one of the difficult aspects, for instance, when using conventional chemotherapy is the use of asparaginase, which is not the most easy drug, at least in my hands, to manipulate. Any thoughts on the role of asparaginase? And for instance, we had a comment from a participant saying, oh, now when using Blina or Eno and regimens like hyper-CVAD, maybe we can get rid of asparaginase. So what are your thoughts about this kind of comments, and what is the exact role of asparaginase and its importance in the management of these patients? And if there is another drug you want to mention, please don't hesitate. Who wants to start?
I can start.
Please.
So I think there are many reasons why it has become an essential drug. I mean, there's no doubt it's highly effective. We know that it changes the asparagine concentration in the spinal fluid, and CNS leukemia is still a challenge. The fact that we can do therapeutic drug monitoring and clearly demonstrate that if you don't have sufficient exposure, then you don't have the same efficacy. Both for when it comes to truncation and when it comes to inactivation, there's a number of studies that clearly demonstrate that you increases the risk of relapse by perhaps, let's say, 70%. We don't have similar data for the other drugs. There's some data that indicates that having adverse pharmacokinetics of, you could say, maintenance therapy could play an equal role, but we're simply lacking in general similar data. And I think that's why it has become so profound. It is, on the other hand, also one of the most toxic drugs that we have. So not just because of the cost, but also because of the toxicity. We don't just give it extensively for all our patients. Some groups have done that, but it's clear that the outcome of the lower risk patients in the consortia that have used a lower exposure seems to be really comparable. So due to the toxicity and due to the cost, we tend to limit the use, but that it is highly effective on the backbone that we use today, there's no doubt about that. To which extent it can then be replaced is another issue. And again, we will start off with the groups that have most toxicities. So if you look at the recent British data, where they, for patients that had severe toxicities of various kinds, it may be pancreatitis, it may be fungal infections, where they then replaced intensive therapy, including asparaginase, with Blina, the outcome of the group as a whole was very comparable to the background population. So I think it's likely in the long run that some of these very toxic drugs can be replaced by Blina, but we'll probably start with a patient that first get their toxicities and then you need a replacement. And once we have a situation where we can predict the risk of toxicity, and we are not there today. I mean, we know that, of course, adolescents and adults get thrombosis, but we don't really can predict who should upfront have replacement, but we know we can replace when they have the toxicity. So I think that for some patients, Blina will replace asparaginase and some other drugs.
I like, Kjeld, the way you handle it, because you're making my life easy as a moderator. So if I want to structure this, you alluded to the consequences of missing asparaginase therapy. You mentioned, I think, 75% of relapse. I don't know if everybody agrees, but even if it is
an increment, so it's a hazard ratio of 1.7. It's not that 75% will relapse, but from the low relapse rate, you increase it by 1.7.
Excellent. No, I got it. But of course, we can always say that we will replace all of these old-fashioned drugs and they will retire and we'll get all the fancy new drugs. But actually, there is probably room of improvement with the various asparaginase formulations. Can you clarify to the audience the differences between the various asparaginase and how one can navigate, before going to blinatumomab and CAR T cells and other fancy drugs, can navigate across these agents to circumvent the toxicity, but maybe the hypersensitivity, and I'll come back to this, but also someone mentioned a few minutes ago the TDM, the drug monitoring in these patients. So who want to take over here? Jose Maria?
Maybe I can begin.
Yeah. Please.
So first, you have to understand that the asparaginase we use is an extractive drug in the most of the cases, coming from a bacteria which is E. coli. There have been many variations on the theme, and the first important one was to say, okay, we can use maybe another line of bacteria, which is Erwinia carotovora, which means a bacteria which eats the carrots. And Erwinia was introduced in the 70s, 80s, and it has been shown rather quickly that the half-life was completely different and extremely short, leading to this every 48 hours infusion. And also that basically when you were using Erwinia in this scheme of every 48 hours and to exposure comparable to the parent drug, the toxicity was pretty much the same, which was not the intention at the beginning of the use. Then came Enzone in the 90s, and with the idea, let's say, as soon as this protein is of bacterial origin, the more you give it, the more you vaccinate the patient against it. That is the reasons of a lot of failures of administration. So the idea was to mask the antigenic site, which is the famous pegylation. So the idea of pegylation was two. One, to mask the antigenic site and reduce the hypersensitivity reaction. And the second one was to prolong the half-life. So these were, until recent years, the main brands of asparaginase. They were sold according to different brands, but these were the species. Then came the idea that, say, it's difficult to extract these drugs from bacteria, make a soup of bacteria and then extract. So let's make it with a kind of genetic modifying cell. And it has been done by Medac Laboratories under the name of Spectrilla. And now the Erwinia also is on the way to be manufactured in the same way by the Jazz Pharmaceuticals. And so we will have two recombinant asparaginase, one which is the same than the native one, which is Spectrilla, and the one which is exactly the same than the extractive Erwinia, which is manufactured by Jazz. So these are the main players. The problem for our audience is to identify where does the asparaginase they use come from. And it has been demonstrated that some children even in big countries like Brazil, for example, have received inadequate asparaginase, whatever in purity or in terms of quality, leading to non-exposure to the drug, which was, I would say, a fake asparaginase, which obviously is the most dangerous thing because you think you give a chemotherapy and you get nothing, essentially. So the very important, let's say, health problem for these countries which do not buy to the main sellers is to make controls to be sure to what they give is really asparaginase.
Okay, thank you very much. Kjeld, you'd like to comment on this?
Yes, I just want to comment on two issues. In general, we believe that the asparaginase depletion, asparagine depletion, is responsible for the efficacy, and there shouldn't be any difference between the different formulations. When it comes to the toxicity, we've talked about hypersensitivity. There is more glutaminase activity in Erwinia, so you have higher ammonia level, and sometimes it causes allergy-like reaction, and even it may cause neurotoxicity. It's not a critical issue when you're used to using the drug. And then for the countries where it's not available, and that was also the case in the US during a period, there's been a testing of whether you can desensitize patients so they can reuse PEG. There's no good data. There's anecdotal data, small case series, so it's basically similar to other kind of desensitization, but we don't have any, you could say, larger population data. But it may be a relevant thing to pursue in countries where Vinja is simply not available and you've had a true hypersensitivity reaction.
Can I add to the, oh, sorry.
Yeah.
Can I add to the silent inactivation as well, because we have seen in patients that we didn't know of that they had silent inactivation and that we continued PEG asparaginase, that their levels were going up. You don't know when, so it can take 5 doses or so, but that's kind of desensitizing as well. And these are the patients, of course, that are not noticed if you do not do your therapeutic drug monitoring, and that's you will have more silent inactivation when you use biosimilars, but also with the Oncaspar and Erwinia asparaginase.
Thank you, Jose Maria.
Yeah, and from an adult point of view, I think that the most important issue is to ensure the adequate management of asparaginase in a complex protocols that includes other cytotoxic drugs and also supportive therapy, antifungals, antibiotics. So we don't have the same experience, the same prolonged experience as pediatricians. This is first. Second, the toxic profile in adults is quite different from children. With PEG asparaginase, we do not see allergic reactions. We do not see, we see a scarce number of pancreatitis, and what we see is hepatic toxicity. So this is our issue, the most important issue. The second is thrombosis, but far from liver toxicity. So how to manage this toxicity is the big issue in a complex protocols that are protocols for ALL. And another issue is to ensure a prolonged depletion of asparagine in induction, followed by consolidation, etc. So the best integration for efficacy and especially for toxicity is our big issue.
So can I ask you?
Yeah, just now to comment, Mohamad, on the adult situation, I think that the 2 factors that correlate with toxicity are first age, and I think that we can only with difficulties give asparaginase in patients older than 60, 65. Some do, but it's very difficult in elderly patients. And the second comment is that probably we should not give the same dose in AYA and in older patients. So we have to think about, again, this continuum, decreasing the dose in patient 50, 55 when compared to 25, 30. And the second factors, and it was always already discussed, is BMI. And so the 2 parameters on which many groups are now adapting the dose in the adult population is overweight, BMI, and age. And these 2 parameters help to adapt the dose. And of course, the dose also should be adapted. And it was an important point mentioned by Jose Maria on the chemotherapy backbone you use, because there are cumulative toxicity when you use different type of backbones in induction and in consolidation.
And
Excellent.
also
Thank you very much.
Have to have interest, also a special interest with very active drugs such as some TKIs and also inotuzumab. So drugs that have potential hepatotoxicity, and the proper combination with asparaginase is also an important issue in modern protocols.
Okay, all of you, you have mentioned the issue of hypersensitivity. You mentioned TDM. You mentioned the pancreatitis, liver toxicity. So we do have a lot of practicing colleagues attending. So I want to be pragmatic. So I'd like to ask you, Kjeld, for instance, about what is the your experience, and we have a few questions from the audience about this, with pre-medication to avoid hypersensitivity reactions, and how important is TDM when pre-medication is conducted? And I would say, based on all this, when do you decide to switch among asparaginase products, for instance, to switch to erwinaze or whatever else?
So sometimes if you have patients that have true hypersensitivity and you expose them, their response will reaction so early on that you don't have sufficient drug in the bloodstream to be able to determine whether they're inactivating or not. If you have a patient that have true hypersensitivity, they will be inactivating. So once you've had that situation, there's no data that indicate that avoiding the hypersensitivity reaction by pre-medication prior to the next exposure will help the patient. The question is then, will pre-medication as a routine activity provide an avoidance of hypersensitivity? And we still only have the small series data, which may be selected, but we are at least not in the Altogether consortium convinced that it solves the problem. It may, from the clinical point of view and from the nurse's point of view, seem to be great because you have fewer reactions in some settings. But in general, when you do it, the sufficient monitoring, the frequency doesn't really seem reduced. And the other thing, which is quite critical, you may mask the hypersensitivity if it were effective, and thus underestimate the elimination. So at this time point, we don't provide this as a general recommendation. I'm sure that Inge would like to add to what I just said.
Actually, we are facing a lot of hypersensitivity reactions to PEG asparaginase in our current protocol. It's almost similar to the percentages that we saw with E. coli asparaginase, so 30% approximately. So it's really, really high. And that's why we decided in Altogether to give the pre-medication, at least in post-induction doses, because there's a lot of dexamethasone in induction, and we don't see the allergies in induction, but only after the asparaginase-free interval. So we say that all these doses in post-induction, they will receive a pre-medication. But I agree with Kjeld that we do not see a huge decrease in hypersensitivity reaction. And I think that you should do your therapeutic drug monitoring if you want to use pre-medication.
Can I just add a short comment? That is, if we overall look on why patients have truncation of therapy, and that's really the issue we're discussing here, how do we risk taking away the efficacy of asparaginase? If we look at what is the reason that patients have truncation of therapy, approximately half of the cases are due to hypersensitivity reaction of some sort. Then you have some percentages that have silent inactivation. Of course, you need the TDM. And then you have all the other toxicities, whether it's pancreatitis or thrombosis or liver toxicity or even osteonecrosis, that would lead some clinicians to take the drug away. However, in general, we recommend that the decision of truncate therapy, I skipped the hypersensitivity here because we have a solution with Avinia, but the indication of skipping toxicity needs always to be balanced towards the risk of leukemic relapse. So you could say if you have a low-risk patient that by prediction would have, let's say, a 97% chance of being cured, and that patient have had a pancreatitis, we probably wouldn't re-expose. But many of our patients, and not least the adult patients, have a significant relapse risk. And there we regard the toxicity to be a lesser problem than the leukemia itself. And now we have quite good published data supporting that re-exposure is safe for most of these toxicities, also recently for the CNS thrombosis. The problem, and here adolescents and adults are different, the problem is that the likelihood that an adult patient will have a second episode of pancreatitis is more profound than in the young child. And secondly, the risk that an adult would develop diabetes after pancreatitis is much higher. It's approximately 20%, and it's less than 10% for the young child. So here you could say the young children are different from the AYA group in that setting, which needs to be taken into account.
Nicolas, you wanted to comment on this?
No, I agree on the fact that we have now some clear rules about re-challenging the patient after toxicity. If you have severe pancreatitis, we avoid exposure to asparaginase. If you have a thrombosis, even a CNS thrombosis, and we re-challenge the patient after checking of the permeability, vein permeability, and under some prescription with heparin strategies. We're coming. Our group is coming from the use of E. coli asparaginase without any TDM, and with the learning curves. Certainly, we have a 10-15 years learning curves in 50 centers of our group, but we have now reached a 95% complete remission rate, and without any TDM. And so we think that it's if you have access not to pegylated but to short half-life, you also may use it without any monitoring and re-challenge the patient. And through the use of asparaginase, and it was not a randomized study, we were able to improve drastically the outcome of patients. So just combining asparaginase and a short half-life asparaginase with chemotherapy is feasible, but you should expect to have these learning curves and to improve the management of patients. With pegylated asparaginase, it was a next step, I would say, because for all I think adult groups, it was a new difficulty, so it's clearly more difficult to manage on a daily practice. So our next step, and we will probably pay it in terms of immunization, we will still manage the patient with short half-life in induction and try to expose the patient to pegylated asparaginase after induction. We will see what happens in terms of immunization, but we think that it's more wise for patients up to 60 years old. Also, because we had these learning curves, 15 years to improve our strategy, induction strategy, and when it works and you don't want to move that much, and if we move to pegylated asparaginase now, we should to rethink all our induction strategy and how we combine the chemotherapy, because in adults, when you want to use pegylated asparaginase in induction, probably you have to be more cautious about the combination with other cytotoxic drugs, including anthracycline.
Thank you very much. We have a question here in the same line about side effects from Dr. Ribera, whether asparaginase is completely contraindicated in a patient with a previous history of thrombosis, and if not, what kind of prophylaxis you would use, Kjeld?
It's interesting because we like to have our prejudices confirmed, but when it comes to thrombophilia, there's really no data that indicates that when we use asparaginase that these patients have a higher risk. So when large cohort of thrombosis patients are screened, you find the same frequency of thrombophilia genetics as you do in the background population. So we don't think we have this specific risk. So let's take the most common one, Leiden factor 5 mutation. You'll find that in 7% of your leukemia thrombosis patients as well. But it causes a lot of nervousness when it does occur. So we don't do any pre-screening at the time of diagnosis, and we don't have a different guidelines for thrombosis prophylaxis. We give low molecular weight heparin for these patients as with any other, and we re-expose them. The problem, I mean, being above 10 years of age and being an adult, that's a much more bigger risk factor. And that's another discussion. Should we recommend thromboprophylaxis for that age group? We are still lacking randomized studies. There's a semi-good pediatric, the Truncation study, that indicated that prophylaxis during induction therapy may be beneficial. There's a lot of flaw on that study, but in general, it points in that direction. And there are some studies also ongoing with the oral anticoagulants, but we still lack the outcome data. I think a major question, which there's no consensus about, is when you give heparin, do you also need to give 83? And if you make a survey, some centers do, some centers don't. And we have some guidelines on when we should do it, but I'm sure that Inge or André may disagree. So we lack the studies that really compare these issues. And that's where I think adults were much more prone to do a good study, because you have a higher risk in the pediatric population to explore that specific issue. In the randomized study, 83 was also an option, and there was some data that indicated that may be associated with increased risk of relapse. It may have been a random finding, but it pointed in that direction. So our recommendation today is, in general, when it comes to the protocol, you use low molecular weight heparin. If you do anything else, it's by local religion.
Okay, let's call it clinical judgment. Okay, for the last part of this really lovely webinar, and I'm really enjoying it, learning a lot from all of you guys. We have a case submitted by a member, one of the attendees, a colleague, saying, oh, I have a 9-year-old female child with TALL, so that should avoid all the immune therapies currently available. Normal cytogenetics. This girl has a CNS localization, and we started a multi-drug regimen containing PEG asparaginase. 7 days after the first dose of PEG asparaginase, this girl had an asparaginase level which was undetectable, and there were no signs of any allergic reaction. And here I would like to know the opinion of the panel, how to manage, how to handle the next treatment and the rest of the treatment of this girl. André?
I would say it depends on what day are we at the moment of the discussion, because if you are already, if you do not have the result of the activity in real time, then you are too late to do anything else. But if you have the real time and you say that it is at day 7, or so generally, depending on the fact that you do pre-phase or not, day 7 would mean day 11 of the induction, or day 18 of the induction if you do a pre-phase. Then you have plenty of time to complete, and it has been proven that asparaginase is a drug of importance in T-cell ALL. So I would replace by Erwinia and consider that this patient, for reasons unknown to me, have had pre-existing antibody to asparaginase, and probably maybe to PEG or the region between PEG and asparaginase. So if we want to maximize the 3-drug induction to be a real 4-drug induction, you would need Erwinia.
Okay. Do you share the same opinion in the Netherlands?
Yeah, I do share that opinion, but when it's on your first dose, it couldn't be an asparaginase allergy because you are not exposed to it. So it should be to the PEG part. So you can also consider switching to E. coli asparaginase.
What about in Spain?
The first dose is always problematic. So I am more of the opinion of the Inge. So the possibility of an allergic reaction to PEG is important.
But there's no allergy,
yeah,
no symptoms.
No, but one of the things to know perhaps is to make a TDM at day 0, not before the PEC, in order to detect detect antibodies. So in this case, this detects a background. It's unusual to detect this, but this could put into advice that a possibility of a PEC allergy could be useful. But I don't know if it is systematically done across Europe or across your centers. The TDM at day 0. And the other question is mandatory to make the TDM at day 7 when you receive PEC asparaginase, and not to wait but the TDM at day 14? These are my caveats according to this.
Kjeld?
Yes, first of all, I agree that if you have a response early on, you need to consider, is that a reaction towards the supportive care or towards the PEC moiety? And I just wanted to add that we really need to recognize that asparaginase is an essential drug for the T-cell leukemias. Even though we don't use cytogenetics to stratify T-cells, most of them have genetic aberrations, and some T-cell subsets like the P10 wild type seems to be highly sensitive to asparaginase. We know that intensive asparaginase therapy improves survival. So it is as important as it is for the B lineages, and probably why the cure rate of T-cells has become almost equal to B lineage leukemia. So never skip an essential drug, but you need to think about, do we have alternative explanation to our reactions? And at least for those countries where you do not have access to a vinea, I think Inge's proposal of considering to using native E. coli if you have a reaction to the first exposure is very highly relevant. And 80% of ALL patients are treated in low and middle income countries. So that's a very important recommendation.
Fantastic. Any additional thoughts on this from the panel?
Everything was said, just that it's rare. It's a very, very rare situation.
Well, I guess this is why it was submitted to such distinguished experts. Well, actually, you really did great, guys. I hope everybody has enjoyed this broadcast. It's quite incredible that with more than 90% survival, we keep on, searching and digging deeper and deeper. And this is really the beauty of what we do, not only allowing to extend survival, but also improving safety, improving long-term side effects to the patient, and hopefully at some point eradicate these terrible diseases. So it has been a very exciting broadcast. I would like to thank the attendees for their participation, for sending questions. We have another case of TLL being submitted, but unfortunately, for the sake of time, we won't be able to handle it. But I'm sure if you write and reach out to the panelists, Dr. Radu, they will answer to you, I'm sure. And this broadcast will be available on demand within the next 24 or 48 hours. So with this, I'd like to thank you all for your participation. Thanks, André, Inge, Kjeld, Jose, and Nicolas for dedicating some time. I know it's always busy, especially at the end of the day after some long days. So I'm very grateful. And to all of you, wherever you are, please stay safe and keep well, and hope to see you soon. Thank you very much.